now have a panel discussion, and as they come up, I'll introduce them. Andreas Kramer is from the University of Calgary here. He's a intensive care physician specializing in neurocritical care and organ donation, prolific researcher, and the medical director of Southern Alberta Organ and Tissue. Okay, and now it's Give Life Alberta. Awesome, thank you. I didn't get my T-shirt yet, but congratulations. Mypinder Sekhon is intensivist at VGH and is now researching brain injury. We've seen some of the work. And Murat Slasarev is from London, Ontario at Western, and also medical lead for donation with Ontario Health in his region, and is a researcher in death and dying. So thank you to you guys. What we're going to do is spend 5 minutes each just kind of showing the relevance of this sort of research and the controversies with NRP, and then we'll open the floor for some discussion. So Andreas, can you start us off?
Sure. Is this on?
It will be.
There's the light on.
Okay, talk into it.
Okay.
Yeah, got it.
Perfect. Wow, that's some pretty impressive research. So kudos, wow. I think I'm just overwhelmed because of how difficult that type of research is, speaking as a clinician in the intensive care unit. Maybe to start, I just wanted to reiterate and elaborate on a couple of points that Dr. Dhanani made in his preamble. I think that when people envision what a typical organ donor, deceased organ donor looks like, who that is, a common idea would be that it would be a young person who has been involved perhaps in a tragic motor vehicle collision and has sustained a devastating brain injury that has culminated in them progressing to death by neurologic criteria, what we used to call brain death. And they would then, as Dr. Dhanani mentioned, be able to potentially donate very healthy organs, often 7 or even 8 different organs. The truth of the matter is that as we approach 2025, that is not the typical organ donor. In Alberta, somewhere around 80% of deceased organ donors have died either because of a cardiac arrest that has resulted in deprivation of oxygen to the brain and what we call hypoxic ischemic brain injury, or they've died of a cerebral vascular event of some kind, an ischemic stroke or intracerebral hemorrhage or subarachnoid hemorrhage. And typically they would be more in the range of about 40 to 60 years old. And then, as you heard, increasingly, in large part because of the type of care we provide in the intensive care unit, which has really advanced over the past 20, 30 years, it's less common for patients to progress to death by neurologic criteria because of some of the measures we take to prevent that. And so increasingly, organ donation happens after death by circulatory criteria, or what's also known as DCD. And of course, as you heard, during the dying process, the organs are subjected to warm ischemic time, and so those organs can still be successfully transplanted, but they often don't function as well initially when transplanted into the recipients. There's what we call delayed graft function, and it puts transplant clinicians in a difficult circumstance of trying to decide whether these organs are going to be viable in a recipient or not. So just to contextualize that a bit more, in Alberta, when we have a DCD potential organ donor, we're only able to actually allocate and transplant the liver roughly maybe 25 to 30% of the time, because the liver is so susceptible to ischemia during the dying process. And so this is why the technology of NRP is so exciting, because it means that the organs can essentially be resuscitated inside the donor's deceased body before they are recovered. Some of you may have seen some dramatic pictures what the abdominal organs look like when the patient has died and has been quickly moved from the intensive care unit to the operating room, and the surgeons open up the abdomen, and the organs are dusky looking and blue, and in comparison, there's photos of what they might look like after, say, 30 or 60 minutes of NRP, and they've pinked right up, and they look actually quite normal, and can be then recovered very similarly to recovery of organs after brain death or death by neurologic criteria. So if this is so exciting, what's the hang up? And so it turns out that even though with NRP measures are taken to try to prevent blood flow from being restored to the brain, in fact, there is a surprising, perhaps, degree of collateral blood vessels that can actually find alternative routes up to the brain. So with abdominal NRP, without getting into too much detail here, usually the aorta is either clamped or there's a balloon placed in the aorta to obstruct it and prevent blood from going up towards the brain. In the case of what we call thoracoabdominal NRP, the surgeons would typically put clamps across the major blood vessels coming off the aorta and going to the brain. But there, even with that, it's still possible for blood to find its way through collateral blood vessels up towards the brain. And so why is that important? Well, because the definition of death is it's not irreversible cessation of blood flow to the brain. We can restart the heart, and so it's really not irreversible. It's permanent cessation in the wording of the Canadian guidelines, because there's no intention to restart the heart under the circumstances of withdrawal of life-sustaining measures. And so this raises the question of, well, if there can be blood finding its way to the brain after the patient has been declared deceased, well, are they really deceased then? Are we essentially then violating the dead donor rule by recovering organs? The dead donor rule is just an ethical principle that's widely embraced in organ donation, and really is the law as well, which is that we don't remove organs from prior to death, and that removal of organs shouldn't be a factor that's contributing to or causing death. So that's where the controversy is, and that's where this type of research to ensure that we're not restoring blood flow to the brain becomes important.
Thank you, Andreas, for the context, actually, the real world context of what you see every day. Mip, can you take that further on to kind of the research angle and the context of that, trying to answer these questions?
Yeah, for sure. First, I wanted to say thank you for having us, and also congrats to Murat and Matthew for really exceptional work. I'll get to that in a second. One thing I just wanted to touch on was the research that we do during this process. I tried describing this to my mom. And I said, so often we research a disease, and in this case, we're not researching a disease per se, we're researching a process, and a process that every human being has ever undergone and will ever undergo, except for maybe Elon Musk. But so we're researching a process, and the way that our research group kind of came to this wasn't actually with a donation-centric view. We're cardiac arrest researchers, and we had done research on cardiac arrest patients, but that was hours after the cardiac arrest had taken place. And by that time, it's too late. And so that's a very, now upon reflection, we can look back and say there was a very reactive approach that we took. And so the dying process, and this research actually came from a patient's family, and a comment that they made at the bedside and his parents, that during his withdrawal, he timed out. Michael was his name. He was with us or his parents were with us in Toronto presenting at the CBS donation stream forum last week. And one comment they made at the end of the day when we went to go inform them that, oh, this is not going to work out, was his dad said, well, I looked into his eyes. He's gone. And so it kind of hit us at that point. Well, perhaps what his dad was saying was he's looking into his eyes. He's assessing his own son's brain function. And while his heart was still ongoing, that his son had died. And so that's what kind of led us down this path of doing this, and very proud to state that both Laura and David, the parents of Michael, are partners in this, and actually have helped develop some of the aims. I'll get to NRP in 30 seconds, I promise, honey. But it's interesting, the consent around this, and I was telling a few people earlier today, like, this is incredibly invasive. This is a process by which we are postmortem removing the brain, removing the heart, removing the spinal cord, and banking those tissues for future research. We get blood specimens before the palliation process, during the dying process, with the grieving family there, and then immediately after death. So this is very intrusive. And this is certainly a sub-selection of people who are very motivated, but our consent rate is in excess of 70%. And each consent takes about an hour and a half. And innumerable times we say, you do not have to do this. You do not have to do this. But many people during that moment are very giving. And we follow them up, and we hold interviews months down the road as well. And the consistent theme that we always hear is something good has come out of something bad. And the contribution towards science and the functioning of the human body, but also to donation sciences through the dying process research, I think is really unparalleled. As it pertains to NRP, I only learned what NRP was maybe six or 8 months ago. I was kind of remotely familiar with it. It's interesting. I had not thought that of the things that Andreas had brought up, that resumption of blood flow to the brain. But obviously that's very central to how we should take this. There's clear benefit for graft organs, and so I think we have to balance the beneficence of the benefit for transplant recipients with the non-maleficence and doing the donor no harm. And so how best to do that? I think it depends. My personal opinion is it depends on the type of NRP. In the abdominal version, I suspect anyways, from what I've read and learned and talked to people in the States, the risk is relatively low. And I think the study that Murat will talk about is really cutting edge to help inform that is safe. In TA NRP, I think that's a different kettle of fish because the heart restarts and the proximity of blood vessels that go back to the brain are much closer, and the risk is higher. And so in that case, I think we need to be much more rigorous and probably thoughtful of how we assess resumption of flow and function. And at least in a small cohort of patients, use gold standard measures. So very interesting, very fascinating. And it's really neat to see Canada lead the edge on this kind of work.
Thank you, Mip. Great insights. Murat, tell us more.
So Sani asked me to talk a little bit about ethics of NRP and what's at stake here. I'm really not comfortable sitting in a chair speaking. I usually move around, as some of you may have seen me do, but I'll try my best here. But I wanted to reflect on what Mip just said. he said he didn't know about NRP 6 to 8 months ago. I didn't find about NRP a little bit early than him, but 10 years ago, I could have not imagined doing this kind of research, right? Like I was in brain blood flow resuscitation, sedation, critical care trials, that kind of stuff was my thing. And today was actually a full circle when, looking at both of our trainees present very complicated, very advanced, cutting edge studies that no one else in the world has done. Has been, it's probably the most rewarding thing. And I leaned over to Mip and said, isn't this cool, right? Because this is actually, I think, the most rewarding part for any researcher, right? I'm extremely thankful to this community because CDTRP, I remember, was it probably in...
I'm not that old.
No, I will say that, Sani. I think we were in Tremblant meeting, right? And I came over to Depart was running, where I remember this. And we said, hey, like we can measure brain activity during Depart because we were one of the sites that was recruiting into Depart. And that's how some of the work that Matthew shared today was born, right? And then I said, hey, I can also do TCD. Let's put a TCD on. And that's basically how it all started. So I think this community should be extremely proud of the work that was presented today because it's directly informed by this community. And special thanks to Lori for setting this up many years ago and for continuing to evolve this amazing group. So now I'll talk a little bit about US. Is anybody following what's gone up in the in US in the last few years? So I have been following that, not so much the election, but what's going on with NRP. So let me give you a few things about the United States. I love US, right? Because they're so innovative. They really want to do things first, and they're really are first to jump into a lot of things. But I'm not so sure if the way they approach NRP is something that Canada wants to follow. And the reason for that is that donation is primarily based on trust, right? And you would say, well, why does trust matter? Well, we know from a decade ago when there was a scandal in Germany about transplant programs adjusting the wait list patients and sending organs to patients who were not top of the wait list, but their own patients. It broke into the news and the donation rates have gone down 20–40%, and they have not yet recovered in a decade. So that's a direct indicator of how critical public and healthcare provider trust in the institution of organ donation and transplantation is. And so when we think about NRP, there's really three things that we conceptualize ethically. The first one, Andres already mentioned, we've just declared somebody dead because their circulation has stopped. We waited 5 minutes to call it permanent. And then we take them to the operating room and we restart circulation using a pump inside that patient's body. Is that patient alive or are they dead? Well, it depends where they are. Because in Canada, as of 2023, our guidelines state, as long as you can maintain permanent cessation of blood flow to the brain, you can restart regional circulation. Because death is defined as brain function, and in order for the brain function to be there, you need brain blood flow. And so as long as you can prevent brain blood flow to the brain, death determination stands. In the United States, death is defined in something called UDDA.
Can you hear me?
Universal
Yes,
Death
I can.
Determination
I
Act.
can hear you.
Federal law.
There's a very interesting discussion happening.
Is irreversible cessation of circulation. So resumption of any circulation inside the body violates that federal law. And this is exactly what many groups have picked up in the States, and legal scholars have written papers on this. And the transplant community came back and said, hey, well, the intent matters here, right? Because, the intent, the donor family intent is to maximize success with donation. Our intent is to save patients' lives on the wait list. And the scholars interpret this say, intent, the law doesn't take that into account. You are violating the law. And I was at a conference in Philadelphia last year where a prominent scholar in law and a partner, top law firm in US, advised all the NRP program leads to seek independent legal advice in case their case is brought against them. The second issue is around brain blood flow, right? And so we're using these surgical safeguards to prevent blood flow to the brain, to limit it either to the abdomen or to the chest and abdomen. But how do we know they actually work? Because if they don't work, let's say they fail, or if there's collateral circulation, there is a resumption of brain blood flow, which would violate death determination even in Canada, and it can put donor at the risk of harm through sentience, right? Theoretical, but possible. I agree, less risk with abdominal approach, but much higher risk with thoracoabdominal approach. And if it happens with the abdominal approach, you just turn off the pump if brain blood flow and activity start. What if you doing a thoracoabdominal approach and the heart is beating now, so the pump is actually off and the heart is providing the circulation and you detect brain blood flow and activity? What do? Do you stop the heart? Is that inducing death? Some have argued, so American College of Physicians has put out a statement in 2021 that equated the ligation and tying off blood vessels that carry the blood to the brain to inducing brain death. And their reasoning was that we don't know how much time passes from circulation stopping to cessation of brain activity and function. And now we are getting some data from MIP's lab and ours about that relationship that was presented today, but that's definitely reassuring. The last part is about precision, surgical precision. The surgeons are doing very complicated procedure, and you would want them to do the right thing, right, every time. And there's a paper that just came out by Dale Gardner. They looked at 49 OPOs in the United States that are doing NRP, and only 47% of them had a policy about NRP. The number of cases on average was about 8 per OPO, but it ranged from 1 to 52. So the paper's rightfully called Wild Wild West and NRP, right? And so that's worrisome. But it wasn't until this year that I got really, really worried. I was in New York in September, and we saw a letter that was addressed to the Health Services Administration, which is a federal branch that oversees donation in the United States. The letter stated that OPOs around the country are violating bylaws and policies related to organ procurement with NRP. And the writer stated that in at least 3 cases, they observed resumption of brain blood flow during NRP, and that they have brought up this to the OPOs involved, and they were ignored. And, you know, it luckily coincided with another thing going on in the United States around September, October, so it didn't get a lot of attention, but you can see that a particular interest group can get hold of that information, and now we have federal lawsuits, attention drawn to the potential perils of NRP. And I think we should be very careful about how we approach implementation of NRP in Canada, because if we don't do it right, we're not only risking NRP, but we'll lose trust in donation after circulatory death, donation in brain death, and ultimately we'll have fewer donors and longer wait lists and more death on the wait list. So this is a very serious matter.
Thank you, Murat. We've gone a little bit over time, but I couldn't stop any of these guys because it was amazing. So director's prerogative, I'm going to take 10 minutes and we'll stretch the session. Questions and comments to really 5 world leaders here. And I think we've got something in the back. There should be a mic. There's 2 in the back. Well, the guys online can't. So run to him. Erica, run. Yeah, run. Oh gosh. Okay, Matthew.
So I'm gonna ignore the great commentaries from our 3 elder statesmen and ask one to Jordan, a very specific question around and I forgot the name of the blood marker that you were measuring.
UCHL1.
Were you measuring that where in relation to WLSM? Was it one-time measurement, or were there multiple measurements before WLSM or after? I'm just curious about the logistics of that.
Great question. And so we were measuring this generally like the hour before WLSM, but we have plans to potentially put it back a day or two so we can actually know earlier on whether or not that is predictive. And we were measuring that within the arterial circulation. And so it's generalizable for most people to be able to get a marker like that. Yeah.
Can I ask a quick, sorry, go ahead.
Oh yeah, just a quick follow-up. And this is not like some fancy research platform. Like this is a point of care device that you get a result in 15 minutes. So like picture an organ donation specialist at consent measuring the test, getting the level and saying, okay, with such and such certainty. Now, I think one marker is never going to be good enough, but when you there are, Jordan didn't show a number of other markers. When you combine them, the specificity goes up even further. And so with a certain level of certainty, you can say, okay, this person will die within this amount of time. And that is irrespective of sedation. Fortunately, our sedative administration did not correlate with anything. But the other thing too is like, we're talking about NRP and the pragmatics of making sure blood flow doesn't come back. We have a resource limited healthcare system. We can't just set up NRP on every single case and hold an OR and cardiac surgeons and perfusionists and blah, blah, blah. So this could potentially be a risk stratification tool to pick the cases where they may pass.
Quick comment. It's also in a way a question related to this. So we have a publication that's just about to come out, just validating the DCD N score for the purpose of predicting time from withdrawal of life-sustaining measures to well described and validated in other studies score for accomplishing that. But we've also added neuroimaging information to the DCD-N score, and it's actually quite a powerful predictor in combination with the DCD-N score in predicting that time frame. And so I guess my question would be, wouldn't biomarkers just be a reflection of the same kind of thing? And perhaps I don't know if maybe the patients with the higher levels had loss of more cranial nerve reflexes and more cerebral edema. But I don't know, maybe there's something unique about that biomarker, or what are your thoughts there?
Yeah, great question. So again, we didn't show the data, but motor score is not nearly as predictive, actually not predictive. We do have cranial nerve reflexes, same thing, not nearly as predictive. The biomarker comes from neuron cell bodies, so the sort of machinery of the nervous system. And I think we also didn't show other data to show that neuroimaging findings like optic nerve sheath diameter, so a surrogate of increased intracranial pressure, is also predictive. So I think what we're talking about here is taking a brain-based approach. Like, we've defined death based of, a brain-based definition of death, but sometimes we look at other manifestations, principally the cardiorespiratory systems, to inform when the patient may die. But the question I've always had is, well, you've got that patient and you're like, oh, I think they're going to obstruct. I think they're going to obstruct. And then they don't obstruct. And they keep breathing perfectly fine. This is a quantifiable numerical method that does not require interpretation from a clinician or sets of clinicians, and also is not affected by confounders like sedatives or seizures. So, I mean, we're in medicine, we all know what a blood test is and a certain threshold. And so in this cohort anyways, it is actually quite a bit more specific, combined with another couple biomarkers.
So piggybacking off of that resource comment and Murat's conversation about what's happening south of the border, I mean, we have a lot of folks from different provinces here. In the States, they've had great experiences in certain places with donor-specific hospitals and centers. We have a centralized healthcare system. Why have we been so slow to do that here? Because it's such a high-stakes game, right? Because if we do it wrong, it's a big problem. But if we do it right, it's great from a organ utilization and also for the families, because we have specialized bereavement counselors. They're doing it a lot. It's a much smoother process. I'd love to hear your thoughts.
Wow, getting into controversies. Awesome. So everyone understands the idea is to have a separate center where people undergoing withdrawal of life-sustaining therapy or potential brain death would then move to a specific hospital within your region that then would go through the withdrawal process and a donation process, plus or minus the NRP process. And all those skills, resources would be located in one place. Andreas?
Yeah, wow, that's a challenging question. I pretty fundamentally disagree with you, actually. In my opinion, moving patients at the end of life is not a great thing. Families generally don't like it. I suppose if they're very motivated to donate and you tell them that this is the best way to make that happen, of course, many families are very gracious and they're willing to do whatever it takes. But this is a room full of people who are very enthusiastic about donation. Not everybody is like that. I think that what you're proposing would negatively affect consent rates. Even within Alberta, though, we have differences of opinion about that. So in Edmonton, who started doing donation after circulatory death before Calgary did, they've chosen to centralize it for some of the things you're getting at. A lot of specialized knowledge and expertise pertaining to DCD, that it makes sense to centralize it in some ways. On the other hand, in Southern Alberta, we took the approach, we thought it was far more patient and family centric to bring the teams to the respective hospitals and do the DCD there. It was more work to do it that way. We had to do simulations in each of the ICUs and ORs around the different hospitals. We still don't do that for centers outside of Calgary. I wish we could, but we're not resourced to do that. So Lethbridge, Red Deer, Medicine Hat. So there's differences of opinion about that. I think if NRP were to become the standard of care, it makes it really challenging, right? Because it's not a very portable process. There are US centers or donation programs that do take NRP out to different hospitals. I can't see that happening in the short term in Alberta. And I know, with all the discussions we've had in Alberta around NRP, if we're going to start doing it soon, it would be in Edmonton, specifically at the University of Alberta Hospital initially. And if there was a patient in the community that was going to be a DCD donor, they would need to be moved, right? And so that could negatively affect consent rates. I'm actually really worried about that, what would happen if NRP became the standard of care in that regard. Anyways,
I'm
was
going to have to cut you.
long-winded.
Sorry, Murat. I think that we've opened up some great discussion for our break, the party tonight, and the after party tonight. I want you guys, please, a warm thank you to our rising stars and world experts. Thank you so much.